Hello, everyone. This lecture is about assessment, the assessment process, just as an overview of the assessment process. And we started part of it in the class, but just to make it complete, I record the entire lecture. So we explained that the process of diagnosing a case is different than assessing a case. And diagnostics is part of the assessment process. Diagnosing means identifying a disorder and identifying its signs and symptoms. However, assessment is looking at the entire picture, putting things in context, and it goes to a broader level. Diagnosis or assessment in general is the key to the treatment. Of course, you can provide treatment in some cases without knowing the cause and the diagnosis and so on. But your treatment is going to be more efficient and more targeted if you start with the diagnosis and with the assessment part. Because when you diagnose, you pinpoint the area that is an area of need. And then you focus all the time that you have and the resources you have on targeting that area of need so you can accomplish the treatment faster, and you can certainly, you'll be able to put the resources and focus everything on the area that needs the intervention. So treatment has to start after diagnosing the problem, because also diagnosis or assessment determine if there is a problem and if the magnitude of that problem, how serious, how severe, and so on. So diagnosis is specifying the etiology, naming the disorder, specifying the causes of it, explaining this, listing the symptoms, and in a very objective way. Yes, and also we spoke about the difference between a screening and the diagnosis. A screening is a very brief way to look at the symptoms and signs in order to determine, not to diagnose, in order to determine if an assessment is needed. Because an assessment in speech-language pathology, especially if the concern is language, it could take about more than 8 hours. You first have to spend time, collecting case history and interviewing and all of this. And also you have to sit with the patient or the client a number of hours to do some formal or standardized testing. And in addition to that, you have to score your data. You have to organize the data you have to interpret it, and finally put everything in a report. And that report is quite a time-extensive task. So that is, many hours that are needed to evaluate or to assess a case. And we want to cut down the number of hours because, at least in my own experience, every 100 cases that I have evaluated, about 20, in the school system, not the ones that are referred to me as a consultation. In the school system, on average, about 20% of the cases that I evaluate would be in need of service. So the majority, in other words, of the cases you evaluate will not end up eligible or receiving services. But we want to clarify and make sure that they do not have a disorder, or if they do, that we have to service the person. So a screening is a short kind of a short or a brief period of time where you give a few tasks to someone to see if there is a stronger indication that there is a problem. And if there is, then you recommend for the person for a full assessment. So again, you cannot diagnose in our field. You do not do screenings to diagnose disorders. You do an assessment. So again, diagnosis is more very, very objective, restricted to evidence, to scores, restricted to standardized or some kind of testing that you do where you have as scientific evidence to support the conclusions whether someone has a disorder or doesn't, and how to look at the symptoms, identify them. If the person has this problem, what are the signs that are given as evidence? This person does this and that. So the idea is test scores are test scores. You cannot use them to give a diagnosis simply by just on the virtue of test scores. And like the Wechsler, developers of Wechsler tests tell you, tests or test scores do not diagnose, but you as a clinician, you make the diagnosis. Because someone might have say for example, have a lower IQ that would place him or her basically in the deficient range, intellectual disability. And when you look at their environment, maybe that person was not given the opportunity to receive the adequate sensory stimulation that the environment should give them, like not listening, not hearing a lot of language around them, not having the opportunity to practice, not having the opportunity to acquire the skills and develop them in a normal way. So if that is the case, then that person is not going to be diagnosed as having an intellectual disability. That person will be given some kind of a program like what in the school system, RTI, response to intervention, is going to say, take this person, design a brief plan, give them some strategies. They are not labeled with it as having a disability. So, but you give them the chance to learn the concepts and things that they didn't get a chance or were not exposed to. And if they learn these skills at an adequate rate, like most people, then there is no evidence of a disability. If you do that intervention, of course, when you start, you get a baseline. Say, this is where the person was before we started the intervention. And you implement the strategies, and you monitor and collect data as on an ongoing basis until throughout the period of RTI. Then at the end, you do some kind of look at the data you collect and compare it to the pre-intervention data, and you say, is there a difference? Did the person improve significantly? If the answer is yes, then the person does not have a disability. A disability, it tends to be more persistent, and it tends to, the person will have a hard time. They will learn, but they will learn at a slower pace. And that slower pace would not enable the person to catch up and to, to develop the skills in a reasonably, window of time. Reasonable window of time. So as a result, we say, well, it is clear that after all this intervention, the person is not learning as efficiently or as fast as possible, and we need to go back and evaluate, maybe using different tools and so on that look more deeply at the problem. So again, this highlights the idea that diagnosis, that just only simply just diagnosing a problem is not as, it doesn't tell us all the answers. But when you do an assessment, it is more comprehensive. It tells you more. And the diagnosis is only one part of the assessment. Evaluation, the term evaluation is used synonymously with assessment in the field of speech-language pathology. So when you say, I'd like to evaluate someone, or someone will have a speech-language eval, we'll say a speech-language assessment. It is the same. But the word assessment, for example, as it is used, let's say, in the real estate market, when someone asks for a home assessment, you do not just go and assess the inside of the home, for example. You assess the outside, you assess the yard, you assess, the fence, you assess everything at all that has to do with the property inside and outside in a comprehensive way. So again, the term assessment is comprehensive, and it includes diagnosing the problem, giving a name to it, defining the etiology, or trying to look at the causes of the problem, specifying the effect of the disorder or the problem on the person's life, academic success, work, social relationships, and so on. Making a prognosis. A prognosis is you look forward and say your vision for the person. Where do I see this person 6 months? If they are given adequate intervention, and if they are given support, family support, teacher support, everything that you need to have in place, what are your expectations? It is unethical to put a time limit on treatment. You cannot say, oh, this person in 6 months, the problem will be gone. That is unethical. We do not have control over time and control over the future. So, but what do you say in a prognostic statement is something like this. By the end of your eval, of course, you'll have some indication about what the problem is, how the person is likely to learn, and so on, and what are the possibilities of the person improving in that regard. Is there potential for improvement? So we word it like this. Given, for example, family support, given school and family support, given whatever conditions that you would like that you see must be in place, giving adequate medical care, whatever it is, and so on. So then treatment is expected to produce significant improvement in the performance of the individual. You could phrase it in different ways, but the idea is to say, would you expect the person to make significant gains? Will you expect the progress to be slow, for example? For example, if someone has a neurological disease, if someone has, certain things that will always be like autism and so on, how far do you think the person will progress? So these, again, are guarded. When you make the statement, you have to think about conditions, and you say, if these conditions are present, then the improvement will be like this or that. When the prognosis is poor, let's say someone has had a brain injury that affected a significant part of their brain that is dedicated to a certain function, and you know that the damage is quite severe and the window for improvement is limited. You don't encounter, hopefully, as many patients like that in communication disorders. But in that case, they say the prognosis is guarded. It is like there are things that are that would limit the progress because, of this and that. So the assessment includes also making recommendations. You make the broad lines at the end of your evaluation. You have a summary always, summarize, and then immediately after, say, in the summary, you identify the problem. For example, in language, say, well, this person does well in morphology, and does well in syntax, does well in semantics, but doesn't do well in social communication. So you identified the areas of strength, and then you look at the areas of need. It's better to call them areas of need, because when you say areas of weakness or weaknesses, that is judgmental, and you want to be positive. So the areas of strength and areas of need. Then you say the areas of need. What does the person need? Social communication is poor. Why? For example, number one, the person doesn't initiate. The person has difficulty initiating communication with people, asking them questions and answering questions. That is an area now that you are going to focus treatment on. It could be also that the person doesn't take turns, or the person speaks in monologues, on and on and on, not allowing someone to take turns. But if you ask them a question that requires a single word or two words, they tell you a big, gigantic story. So there's a problem here. So let's say you identify these components, and in order to do so, you must know what social communication is about, what areas it includes, and so on, like morphology, syntax, and so on. So you identify the specific area of social communication that has the impairment. And based on that, you make recommendations focused on how to remediate that problem. So now, by doing these recommendations, you are laying out the grounds for the treatment. You are giving the broad lines for the treatment plan that you make. And the treatment plan is a whole different process. The class here is diagnostics, but at some point I will give you an idea about the treatment plan and how it works. So again, assessment does include diagnosis, and it includes many other things, and it enables you to understand the disorder and give recommendations for remediation, and to be able to, again, give the kick-off start for treatment. We said the term functional, as it is used in the Skinnerian sense. As in the past, they used to say a functional disorder, like someone has a voice disorder, for example, and there is no visible biological problem that is there that is causing it. Then you say functional. The fact is that this term should not be used, because everything that we do or that we fail to do is caused by some organic problem in the brain, directly or indirectly. So again, these are all terms. You might encounter them sometimes, and so anyways, differential diagnosis is the process of diagnosing a problem when more than one problem are suspected. Or, for example, I get the question, someone refers a case to me and says, we don't know if the person has auditory processing problem, if that person has memory problems, or if the problem is a language disorder. And they rely on your expertise to sort these out. And then what you do is you test in the three areas, basically, and then you determine, exclude, the ones that do not have it, and then find more evidence to support that the person, if they have, say, a language disability, then you say, yeah, definitely there is a language disability. But again, when you have more than one problem suspected. So the components of the assessment include case history and background information that you collect about the patient or the client. And you also do, this is before, the background and history you collect before you see the person. And then the formal testing, it involves standardized assessments and sometimes criterion-referenced tests. Sometimes, just quickly, standardized means that the test before it was given to to a person, it is given to a big sample, a representative sample of the entire population of the United States, for example. So you create standard norms, and you use this and say, if the general population, was able to answer this question correctly, then I would expect the person, if the person who is taking it answers it, then they don't have a problem. If they do not answer it, then they have a problem. When they do not answer enough of the problem of the questions, and they can't do enough of the tasks, then they fall below average, below the standard norms, and then we call this a disorder. Criterion-referenced, instead, goes directly to the research. Let's say, for example, you go to the language acquisition and development book, and you have charts to say, by 24 months, between 18 months and 24 months, the child begins to speak in sentences. They start to combine words into phrases, and they start to make little small sentences. And then, so you look at this developmental stages when skills are supposed to appear, and then you give a criterion reference test to someone, so they compare that to the data that the research has already done, but these are not standardized. The criterion referenced, they look at the research and the measures, but they do not go and the tests were not given to that wide sample, the population. Again, you just compare for this criterion referenced, you compare the performance of the individual to the developmental norms that are established by the research. The third part of the assessment is the informal assessment. And this actually is more than the others. The informal assessment involves information from the case history. Information, like for example, we'll have a couple of things here, examples coming up. But for example, you might have a piece of information in the case history that will help you interpret a score and say, why is this score high? Why is it low? If you look at the case history, sometimes you will be able to explain why. Interviews with parents, with teachers, with caregivers, any person who knows the client intimately, or if the client is able to communicate well and stuff, you could also interview the client, especially in the case of adults. You need to collect from them. But if they have a significant aphasia, then you are going to have someone else who can help with the interviews, their wives and so on, or husbands. Part of the informal assessment is clinical observation. And also, you analyze your scores, you score the performance, and you analyze the data that you collect. And let me just go here and explain about the interviews. So the interviews, if the person is able to, and you can interview them and you ask them questions, that is important. So you can identify what the problem means to them and how they are affected by it from their own perspective. And clinical observation is a very important source of data that you collect. Very, very important. In that, you just sit somewhere and observe the person functioning in a day-to-day activity in the classroom or with a spouse, and you observe and see how they use communication, if there's a problem, if there isn't. So let's say in the school system, if possible, you do your best to go to the classroom before the evaluation starts, and you sit and tell the teacher, of course, ahead of time, and then you just sit in the background without having, you might have the student know, but you don't have to make them know. And you sit in the back, stand in the background and kind of observe how the person interacts and how he or she uses their communication skills. Sometimes, in addition to that, I go to the playground. Sometimes I go to the cafeteria. Sometimes I find ways to see them interacting with other people. And then I write my notes and basically see how the person uses communication in day-to-day life. Sometimes you would have to go to the house to do an observation if the child is in preschool, for example, and you want to see how he or she are communicating in the household. Analysis of the information, that is something you do on many levels. Number one, you get your scores, and then you try to say, what does this score mean? I mean, does it mean there's a significant disability? Does it do this? And if you go back to the items and see why this score is high or low, when the other scores are not as well, developed and so on. So you do a lot of analysis. When you come to a language sample, language sample or sampling is a very important also source of information. You can collect data from it. You want to collect a sample of like continuous conversation between the person and someone else, or between the person and you. So you see them interacting, and then you do like the language sample analysis. If the person is 5 and say 5'9", or so 5 years 9 months, or before 6, you could use a formal language sample analysis, as you did in some of the projects, where you count the words, count the utterances, and the utterances, count the words in the utterances, and so on. Your goal is to find out the mean length of utterances. And why is the MLU important? It is important in this population between 2 years and 5'11" or so, because the greater the length of the sentence or the utterance is, the more complex the language that the person uses is. In other words, if they use longer stretches of utterances, that will predict the complexity of their syntax, and that will predict how mature they are in language, if they are acquiring language above average or below average, and so on. So formal sample analysis, again, it is meaningful from 2 years to 5 years 11 months. But beyond that, it is not going to work, because it's not, at that age, after that age, the length of utterances doesn't mean anything. I mean, it doesn't predict linguistic complexity. Why don't we do the MLU before age 2? Just simply because children begin combining words at age 18 months. So the child before 18 months, they're just speaking in single words mostly. So anyways, by doing the formal assessment, you go to a manual and you look at the score, whatever data you have, and compare it to the standard data, and you say this person shows will develop MLU or low or above and so on. But there are more uses to, for sampling, language sample analysis than this. For example, if an adult has a stroke and you want to get a language sample, does it mean that you have to calculate and stuff? No. But you could do an informal language sample analysis. Informal. You look at it yourself. You can count the words and utterances and so on. And you can make conclusions and say, for example, this person doesn't use language economy. Like I asked that adult a question that says, do you live in Bridgewater? And the person gives me a huge story. So that is not a good answer, because you need to have language economy. Do you live in Bridgewater? The answer is either yes or no. But not giving this answer, then there's a problem. If the person continues to give you that every little question you ask, they give you a very lengthy answer, tell you a story, there is a problem here. So again, when you do the informal analysis, it gives you a lot of information about adults and about children. And you can do it even, even before too, because you are looking generally, doing the utterances, doing the analysis yourself without comparing to standard data. And you can, based on what you are looking for. For example, if you do it for social communication, you want to see if the person answers short questions with long answers. If you ask them a question with how or why, do they give you a small answer? Because that is also a problem. That will be an area of need. So things have to be balanced. So again, language sampling, I personally have been doing it informally for most of the time. So because I get more information out of it and analyze the sample in terms of vocabulary, how diverse it is, how sophisticated is the vocabulary, and so on, and how the sentences, and you look more beyond what the utterances are. So now let's see, these are some activities we planned for the class, and to look at the case history. So I'll tell you the purpose behind this. We might do some of this in the class. Case history includes developmental information, which is from pregnancy, basically. How was the pregnancy? Did the mother take drugs? Did the mother take any medications? Did the mother have any injuries, bleedings, whatever it is that could affect the pregnancy? How long did the pregnancy last? Was the child born prematurely? And beginning after birth, when did they start to do this and this and that? And you go through to find out if the person progressed normally along the ladder of development. Look at the medical history as part. Also, for example, after birth, the child was kept in the hospital in neonatal care for 5 days. Why? Because she had jaundice, she had difficulty doing this and that. That data is important. You look at if there are head injuries, whatever, medications they are taking, whatever it is that would have affected their medical history, like ear infections, wax in the ear canals, and so on. Family history, you look at, for example, are there people with disability in their family? Like if the person, say, for example, stutters, you want to know if there's a father or the mother, if one of them stutters. If they have relatives, immediate relatives, like the mother, the brothers of the mother, or the sisters of the mother, like the aunts and uncles. So the close relatives, if any one of them has the same problem. The reason is that for stuttering, it has a strong genetic component. So if someone else has it in the family, immediate family, it increases the likelihood that this kind of stuttering you are seeing is going to persist. It will not be the kind of stuttering that will disappear in a few months, as 80% of the cases do that occur between ages 2 and 4. So that will have implications for treatment and how you do your treatment. So looking at the family history, because many of these conditions could be genetic, and if a parent or aunts, cousins, closer relatives have that would strengthen the likelihood that we have a problem that could persist. You look at also part of the case history, academic, where is the child now in preschool, maybe in primary, maybe in high school, maybe in college, not a child anymore. So you look at academic and vocational aspects and how the person is functioning in the school, for example. Is the person succeeding? Do they have trouble in this and that work, and so on? And then you look at the cultural context. Obviously, because the majority do not come from diverse backgrounds, you don't have to do that. But people who have come from minority populations, from immigrants, say African Americans, Hispanics, different groups, cultural groups, you need to thoroughly examine that, because people communicate differently, and that is environment in the culture and the house will significantly influence the way people communicate. For example, I was working in a bilingual program on the Cape at some point, and there was one student from Brazil, and that student, whenever, at some point, the teacher reprimanded him. He did something he wasn't supposed to do, and the teacher, stood in front of him, and he was standing, and she was reprimanding him. The student was looking down and didn't look up at the teacher in the eye. The teacher felt offended because that student, to her, was showing disrespect by not looking her in the eye. However, the Brazilian teacher, who was with us also there and in the department, explained that it is inappropriate if you are disciplining someone and reprimanding a child. They look you in the eye at that moment, they are defying you. They are challenging you. So the opposite, by looking down, they are acknowledging that they did something wrong. They feel shame, and they kind of have difficulty even looking you in the eye, because they're kind of apologizing and feel they shouldn't have done that. So it was interpreted totally the opposite way. If the person doesn't know the culture, then they will miss a lot, and they can explain behaviors that are intended to be positive by the patient or client. They would interpret them to be totally negative. And there are many, many examples like that, you know, in the tone of voice, and we'll come to cover these things as we come through evaluations of different groups. So it's important to look at the cultural context because it will have an impact. For the case history, it is important, of course, if you are dealing with a child in particular or the caregiver, it's important to have them articulate the problem. Do not put words in their mouths. All your job is to make them express as naturally and as spontaneously the nature of the problem and how they see it and what it means to them, the effect of it as they see it. Because you want to provide intervention that will make a difference in the real life of the individual, in the home, and at work, and so on. And when you know these issues and you address them at the beginning, then you get a lot of confidence. They become confident that treatment is effective, they are invested, and they will do whatever you ask them to do. If you give them homework and so on, they will be very interested in doing that because they see an effect. So it's important to have them articulate the problem and their concern so you can understand it from their perspective. Also, it is important to ask them about when did the problem occur, the onset of the problem, conditions surrounding the onset. For example, a child immediately started stuttering or started stuttering at a certain age. You need to understand, when did you first notice this problem? And then, for example, when that happened, was the person taking medications? What is new in the environment that could have triggered that problem to emerge? So this is our goal. And if you know that, that's going to mean a lot for the intervention piece. You also need to know the progression of the condition over time. Is it becoming worse? Does it go up and down? Does it vary? And so on. So if it's steadily, not changing, that means something. If it is increasing, becoming worse as the time goes, that means something. If it is decreasing, if it is sometimes the person is doing well and at times not doing well and fluctuating, that also will tell you a lot. So here's the teacher's input form that you give the teacher a form. I give a form simply asking two simple questions: list the strengths, list the areas of need, and that's it. And leave it open for them to express in their own words the nature of the problem as they see it exhibited in the class, for example, or at work or wherever, from their perspective. So say, please comment on the student's areas of strength and for academic, social, cognitive, and so on, as you see him or her perform in the classroom. Please list subjects that the student is interested in. Why do I say that? Subjects that the student is interested in. We all know if I am strong in an area, I have strengths in it, I am going to like it. Because why do I have strengths? Because I invest more effort and I know more about it, and then because of that I like it and I seek more information about it. So that tells me, indirectly I'm asking them to basically show me the effort. Where is this, the child exposed the most? What areas is the child exposed to the most? Let's say they are good at science. That means at home, most likely they have enrichment. More in the classroom, somehow the child is interested in reading more science books and learning more about science. So that way we'll be able to identify areas that subject matter that the person likes and is most likely successful in. If you know you're not doing well in an area, it's very hard to imagine you liking it if you do not do well in it. Then the other question is the areas of need, and also list subjects the students avoids and or does not like. And basically they avoid or don't like because they do not have enough knowledge about it, about these subjects. And we want to know why they do not have enough knowledge. We can tease this a little bit more through other questions to the parents and the teachers. So that is a very important thing. If you get feedback from the teacher, getting case history information from the parents and the teachers is going to make you understand the perspective that they have, because the teacher could be the one referring the student to you or the parent. So as a result, if you know their concerns, focus on these concerns, answer their questions, and do the treatment based on that, they're going to see the effect immediately and they will be your best allies. But if you don't engage them this way, they wouldn't know what you are doing and they wouldn't see the progress that you are giving, you are making, maybe not. So this is a situation now. We have the purpose of this was a class activity, but the purpose is to show you how important case history is in interpreting and making us understand the case that we are dealing with. Say Daniel is 6 years and 7 months. The problem that is reported by parents or teachers, she has severe difficulty comprehending and producing spoken language. When speaking, even at close range, her voice is very loud. She seems to be impulsive, has difficulty with social communication. So, what are our expectations now? What is in the case history that enables us to understand this more? So that is the problem that's reported. And now I am going to go collect some case history, because case history is not just something that you list there in the report. It is something that enables you to interpret gray scores within their context. So let's see. In the case history, you find out that Danielle snores during sleep. Let's go back. How does that knowledge help me understand what's going on? Severe difficulty comprehending and producing spoken language. How does snoring relate to that? When speaking at a close range, her voice is very loud. Why would someone speak like that at a loud? What causes someone to raise her voice or his voice? Impulsive, difficulty with social communication. So we have one piece again that says the person snores. Of course, snoring is connected to middle ear infections. It's connected to adenoid enlargement. And middle ear infections cause language disorders, speech disorders. They cause social communication disorders. So, but why does she speak loudly at a closer range when she is close to you? It is two things. One is if she has a sensorineural hearing loss and thinks that she cannot hear herself, she raises her voice and thinks that everyone hears her voice like she does. But other people don't have hearing losses, and they will see her as yelling, raising her voice so loud. Or that she might have difficulty with attention and regulating her behavior. She might raise her voice because she's not monitoring herself. So let's go back and find another piece that can strengthen our interpretation. So my interpretation, what I gave you, starting to make sense, just based on the fact that she snores. because snoring in kids, not in adults necessarily, in kids, is the result of enlarged adenoids. Okay, she has been receiving language therapy for 1 year. Now this is a big piece, because you look at these problems here, and even after receiving treatment for 1 year, she has severe difficulty comprehending and producing, and all of this is happening even after 1 year of therapy. That is going to show that the prognosis is a little bit weak and that she's not progressing much. And also, it will show you that the progress that's expected is not going to be the same. You know, like if we knew she did not have treatment at all, then she would be more likely to maybe to show some improvement, because you are giving her new skills she didn't have. But you have given her skills for a whole year, and she hasn't achieved as much, and the problem is still severe. So that is going to change your perspective on the situation that you have. Zachary is a second case, 3 years, 8 months. The chief complaint is that he suddenly started stuttering 3 weeks ago. And that case was in the spring, basically in March. Other problems, he was reported to have poor attention in the classroom. He was in just beginning, preschool. Daydreaming, and had difficulty processing spoken language. All of these three. So stuttering, language problems, attention, daydreaming, what is going on? I need to look at the case history and see if I can find information to help me interpret. Let's see. History, frequent upper respiratory infections. Frequent upper respiratory infections are related to middle ear infections. Most likely, if someone has an upper respiratory infection, it is most likely going to affect the eustachian tube. It is most likely going to lead to a middle ear infection. Of course, that will affect language, and if some chronic middle ear infections persist and become chronic, the person could have a sensory neural hearing loss that cannot be reversed. Another one, the person has seasonal allergies. So does that relate to the upper respiratory infections? Yes. What else? The person has been taking Zyrtec for 5 weeks. Zyrtec is an allergy medication. Let's go back. So the person here has started stuttering 3 weeks ago, has been taking Zyrtec for 5 weeks. So could Zyrtec be causing the stuttering? So in that case, first I went and did my research on Zyrtec, and I couldn't find anything to say that it could cause stuttering. Then I contacted Lilly, the company called Pfizer in Canada, and told them, I asked the question, is there any link between Zyrtec and stuttering in little kids? They said, well, we don't have the data to say that. However, we have 6 months of data that we have not put out there, and we haven't added it to the labels yet. And this data shows that Zyrtec for little kids is going to have a significant impact on the functioning of the nervous system. And obviously, that was what is causing the problem. So I took that information and I sent it to the physician, and I told the physician this is what the situation is, and the physician immediately changed the medication and I worked with the parents. I asked them not to mention anything to the kid, to say that he is stuttering, not to be bothered. Just wait until the medication gets out of his system, because every medication has a half a life, stays in the body for a period of time, and then it decays after you stop. And the half-life of a medication generally is 5 dosages. So we gave him this time, and I said, let's keep monitoring him over 3 to 4 weeks. And indeed, 3 to 4 weeks, the problem decreased and then disappeared all totally. So one single piece, information from the case history is critical. You can use it to interpret data and symptoms and signs. And of course, the snoring is associated with the upper respiratory infections. The snoring is associated with adenoid enlargement, and that adenoid enlargement showed us that his airway is at night is basically blocked because of the adenoids, and the uveal, the soft palate just sits on the adenoid and then blocks his airway, and then he ends up having sleep apnea. That was causing him to lose 30% of his sleep time, and that led to his inattention, to his poor memory in the day, to his difficulty like the daydreaming and so on. So we could explain it simply, the whole thing, based on the case history. So your case history is really, really important. So the process of the assessment. First, who should you interview is the people who spend a lot of time with the individual, with the child or the adult, with the client. Like say a wife or a husband, could be a caregiver, any kind of person who spends a lot of time. In the classroom, if it's a child, the classroom teacher, the main classroom teacher. If there's a special education teacher who sees the child significantly for a significant period of time, they understand the child. And also the parents. So you collect information as much as possible from the interviews. I do some on the phone sometimes, and sometimes through questioning, and sometimes just 5 minutes to speak to them in the schools in person. With adults too, if they are able to, you interview the adult himself or herself. Like when you have a case with a voice disorder or a stuttering disorder. So you just have the person ask them questions indirectly or directly and get the information that you are looking for. How do you ask questions? The worst kind of question you could ask is one that is yes, no, like do you, are you, does this, does that. You want the person to express themselves. You want them to tell you, give you as much information as possible. And that information is helpful. The more information you have, the better you are going to be able to do your job. So you guide you control the amount of information by the questions you ask. And because we want the person to give us a lot of language, we need to ask the questions carefully. You need to ask more open-ended questions. Would you please tell me how you communicate, throughout the day? Would you please tell me how do you see the effect of that car accident on your work performance? How do you see the effect on your ability to socialize with your wife or with your kids or with your, co-workers and so on? So you need to get questions that give you substantial answers, because that, again, the information is really could make a huge difference. Of course, adults, you have to be formal and use their last name, Mr. So-and-so, Dr. So-and-so, Mrs. So-and-so. And unless they come to a point when they are feeling comfortable with you and say, please call me this or that. So the questions you need to avoid are the yes/no questions, questions that don't give you much information. Asking questions to certain kinds of people could put them on the defensive, and they could shut down. They might feel threatened, or indirectly, they might like you and everything, but you keep ask them, you as if you are accusing them of something. And you get this from, let's say, there's a child who comes from a big, some kind of building or some kind of a place where you have like a building complex, an apartment where people with socioeconomic difficulties live, for example. Like in Plymouth, there's a place, Algonquin Heights in Plymouth. There's a big building complex with people who have subsidized housing. So the children who go there, who live there, many of them would have some, kind of situation. And in some cases, for example, so let's move from that example, but in situations where in socioeconomic disadvantaged communities, there's a more likelihood of the police going in, questioning people in their apartments, or taking them and questioning them and stuff. Little kids, when they see someone questioning their parents or questioning them about things, they are put on the defensive, of course. They are looked at as criminals. So again, just try as much as possible, instead of asking, do you, did you, does this, does that? No, you need to say, would you please tell me more about this? Would you please explain? No, don't phrase it as a question. Okay? Someone gives you some statement, then try to get more information if you need by asking another open-ended question to get more clarification. So one big principle when in treatment, in diagnostics, assessment, real estate agents will tell you the three most important things when you look for a home. What are they? 3: location, location, location. 3. And in our case, when you do an assessment or treatment, what is the most important thing the most 3 important things? Documentation, documentation, documentation. Very, very important. You cannot get reimbursement from insurance companies if you do not document. You cannot, you could go write a report or whatever. If you have your data, your progress reports will write themselves. So everywhere, just keep document of the data that you collect from your therapy, from your evaluations, and so on. Observations, we said you observe in multiple settings so that you can collect spontaneous samples, collect information about the behavior, how, for example, people communicate with the patient, how the patient responds, how they initiate, how complex the language is, and so on. You do an otoscopic exam to look at the ear canal and see it is clear, if there are any redness, if there's a wax accumulating, if the tympanic membrane is reddish, if it is so. But again, you can say there's wax, there's cerumen, for example, earwax. You can explain there's blockage here and there. There's redness on the tympanic membrane. You explain it, but you do not diagnose it. You don't say the person has a middle ear infection, because that could be practicing medicine without a license. So what you do is you describe what you see and refer to the person, the specialist, so that they can do their own testing and determine if the person indeed has an infection or what is going on. But the otoscopic exam is very important. And in some cases, I have cases where the whole evaluation goes around the blockage, say, for example, accumulations of cerumen, earwax inside of the middle of the ear canals, left and right. And if that is the case, it produces a lot of problems that you can explain just with reference to the otoscopic exam. Orofacial mechanism exam. First, you look at the mouth. What does it mean if you see someone breathing with their mouth open? The mouth is made to be like a purse. It's closed when it is not used. What does it mean when someone is breathing through their mouth at the time, like at rest, like this? That most likely points to a history of adenoid enlargement, either in the past or now. If the person is doing that, it means the adenoids are large, very large. The person's airway is restricted, so they are opening their mouth to bypass the velopharyngeal port. So that is going again. If someone has adenoid problems, they would have social problems likely. They are likely to have attention problems, memory problems, language problems, because they also will most likely have middle ear infections as well. So it's a whole big list of problems they have, simply if you pay attention to see if they breathe with their mouth open most of the time. So every little thing is important. As you observe, you keep a sharp eye on what the person does or does not. Dental occlusion. You look at the side and see basically how the teeth are aligned, the upper teeth with the lower teeth. And based on that, you get information about how they use their sounds, about the jaw, is it retracted, is it jutting forward, and so on. That will affect speech. And it also will have an effect on adenoid and pharyngeal structures. Facial symmetry. You look at the line of symmetry here in between the face. Splitting the face in left and right. And when the person smiles, see if they have a symmetrical smile, or if they are just, one side is contracting more than the other. See if the person's, way like this. That could also mean some jaw abnormalities. So look for the facial symmetry that can give you information about the craniofacial structures and also the muscular, because when they smile, they have to have equal contractions here, bilaterally symmetrical. If they don't, then that could point to a neurological problem. Tonsils. The tonsils, you have a flashlight and or ask the person to open their mouth. You with the flashlight, you can look. Sometimes with the otoscope, you can look through and you can see the tonsils. If they are enlarged very significantly, most likely in 66% of the cases when there are tonsils, there are also adenoid enlargements. So if you see the tonsils large, look and see if the person breathes through her mouth or his mouth. And look and see, look for other signs. Do they snore and so on? Because that could point you to adenotonsillar hypertrophy, adenoid enlargement together with tonsil enlargement. The tongue. Elevate, try to reach your nose. Depress, try to reach your chin. You have a tongue depressor. Try to reach the tongue depressor. You have put it over here. You test the range of movement and the movements of the tongue. Extend your tongue, stick your tongue out and hold it like this. See if it's, crooked this way or that way and so on. Because that's going to have an impact on speech. Look at the uvula. It is not always an indicator of cleft palate, but oftentimes when the uvula is split, it could indicate that there is a cleft palate over there. You have to investigate it more. But again, it doesn't always mean if there's a split uvula, then they call it bifid uvula, then there is a cleft palate. But again, it is, if you find it and you need to investigate more, look more at the if there's a cleft palate or submucous cleft. Looking at the hard palate, sometimes things seem to be fused here back, but when you look at the alveolar, behind the alveolar ridge, in the premaxillary area behind these top teeth, there is a little wedge. So this is the front, this is the going back. There's a little behind the alveolar ridge, a little area. When the tissue fuses, it might leave an opening. And that, if that is the case, we call it a fistula. Fistula. It means that there's a hole in the beginning of the, between the premaxilla and the hard palate. And when the person speaks, they are not gonna be able to do a lot of the sounds. And by checking this to see if there's a hole there, then you could simply make a big difference. And you also, that points you to examine other parts of the hard and soft palate to see if there are other clefts in the back. Smiling, again, it tells you the status of the muscles. Are they contracting equally, or are there signs of a neurological disease that is causing one side to contract more than the other? We spoke about tongue lateralization, sticking your tongue this way and that way, elevation, depression, and holding it out and sticking your tongue out and see if it deviates this way or that way. Puffing your cheeks also looks at the number one, the strength of the muscles, the oral facial muscles. When you puff your cheeks, you have to hold your lips and tightly. And as you do that, are you able to show strength, labial strength here? Are these muscles strong enough to produce pressure? And is that, when the person going like this, is there symmetry on both sides? Diadochokinetic rates. Diadochokinetic rates. These are simple syllables that are individual syllables, and then you combine them. And you calculate them basically by using dots. So you go, the three syllables we use to calculate diadochokinetic rates are the pa, ta, and ka. So first you say here, pa. And then you want the person to say it as fast as possible, and you time the person. Say, for example, I'm going to ask you to say pa, 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 as fast as you can. Time them 10 seconds maybe, or 15 seconds, whatever it is. And as they say pa, 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 you can't do it quickly. You just go, every time they say pa, you make a dot. And then when you finish in 10 seconds, then you count the dots and then divide by 10 seconds. And that gives you a number, an average. You take that, go to a chart that shows diadochokinetic rates in your textbook, and they are going to say, see if that the rates are fast enough, that requires synchronizing muscular activity and doing it fast. Is the person able to do that, to produce fast speech in an effective way where muscles work together in collaboration? So you do this for that, and also then ta 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 ta. Do the same, and then and then combine pa ta pa 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 pata 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 pata, and then pataka 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 as many times as possible, and then again you count every time, average by the number of times, and you get the average, compare it to the norms, and that will tell you if the person has difficulty with synchronizing muscular activity and producing fast speech. And you do it with kids and adults. And so language sampling. It is important to get a sample that is spontaneous without anyone's interference. You want, it's like having a picture, not to stand there and pause and smile like saying cheese and stuff when it's a false smile. No, you want the person to be naturally communicating, and you take that picture spontaneous, natural, no pretense. So you want to see on the average day, the average hour of a day, what is their communication like? If without that, you do not want a decorated image, you want to see how they are functioning, to see the impact of their communication or lack of it on their lives. So that whatever language they use on a functional basis day to day is going to give you an idea about how they perform. And it will, you can use that to derive. You say these are their strengths, these are the areas of weakness or areas of need in an objective way based on what they can, what they cannot do. So where do you collect the language sample? Obviously, if it's an adult and they come to your clinic, you do that there, in the hospital, in the school system if there's a child. Sometimes you go to their homes. If you are in private practice, they come to you and you do that there. So you can collect a sample by observing your patient communicate with someone else, or by engaging the person directly. Say, please tell me how your life was, how, before, for example, you had the injury. Tell me, how do you feel that is affecting your friends? Or tell me a story. For example, how was your vacation? Where did you go? You want them to start to give you connected speech continuously and speak for an extended period of time so you can examine their communication patterns. And you don't want to be asking too many questions. Sometimes I say to a child, do you know the story of the 3 little pigs? Say, oh yeah. Okay, I'd like you to tell it to me from beginning to end, and pretend that I know nothing about it. So they start telling you the story, and that is going to tell you a lot of information. How is their memory? How do they organize utterances? How they, for example, sequence them, and so on. Because you want your sample to be natural, you want to establish rapport with the child and with the adult. So you want them to feel like they know you, to be natural with you. Because some kids, are very reserved and shy and intimidated sometimes. Like, especially if I'm, at the medical center and kids will see doctor, they will think I'm giving them needles, or, that somehow, they become afraid. So we find ways to make them more relaxed and engaged. So that is building rapport, making the person used to you and making them feel that you are friendly and they are willing to engage with you. There's a special technique that we use with kids, young little kids. And when they come in, for example, for the evaluation, there's a carpet, and you selectively get a couple of toys and put them on the floor. Then there's either 2 chairs or a couch and a chair, whatever. And you put them like you are here, the parent is here, and the child is in between you as the third part of the triangle. You are getting some case history, asking the parents some questions, and the child is sitting there playing. But once in a while, the child looks at the mother. Once in a while, they look at you, go back to their toys. And while they are playing, they are listening to their mom, listening to you. By looking at the mother, if they see that she is speaking in a positive tone, that she is interacting with you in a positive way, they trust you through the mother because they know the mother is trusting you. And by doing so, you are transferring the child's confidence and comfort in there with their mother being there, transferring it to yourself. Because they know, if my mother likes you, then you must be a good person. There's nothing to fear. I am here. I'm not going to be anxious. In 5 minutes or so, then the child will be ready to engage with you naturally without hiding behind the mother and without refusing. Again, in sampling, it is advised to record, but you take permission from the parent before you do so. You try to write down everything that you can. In some cases you can, especially if the child's output is limited. So you try to kind of document so that you can go back and then officially transcribe your sample and analyze it, whether informally or formally. It is important, again, not to be alone with the child in an office or by yourself, because a lot of things can be misinterpreted and stuff. So it is always helpful to have someone there. I will usually have the parent with me, and sometimes they are helpful. However, you do not want them to interfere in what we are doing, because sometimes you are asking the child, tell me about this and that, and then the mother looks and says, oh, you don't do that, you don't know it, do you remember when this and that? She's giving him a clue so that he would answer the question, but that is going to alter the assessment results. And we don't want the child to perform better with cues. We want the child to perform naturally. So, as far as literacy assessment, literacy is reading and writing. A speech pathologist is just about the most qualified person to evaluate reading and to evaluate writing, especially given our background in writing and the brain and all of this. However, the reality doesn't permit us to do so. In the school system, you have a tremendous caseload, and you can barely work with your students. So there is a reading specialist in the school, and that person is responsible for doing reading assessments. It will be great to network with the person, but to give advice, to give some recommendations, but we typically do not do reading assessments in the class. Written language, you are most qualified to do an assessment of written language. Again, the reality, it doesn't allow you to. Writing is evaluated by a special education teacher. But if you do a written language assessment, again, you have the tools, you have the ability to interpret. But literacy, generally, literacy assessment is not a huge part. It's not really part that we do, given the caseload. If you have your own practice or a private hospital or something, they can have you do this or that. That is fine. Stimulability testing, basically, you want to determine if the person is able to perform a task. Now you have identified the person as having a disorder, say a speech sound disorder. They can't say, when they say sh and ch, or some alveolars and palatal, they say smile, cat, share, match. So they have a lateral list, but you want to see if they are stimulable for the correct sound, correct production, if they are ready. So say, okay, now say cat, They say cat. Now say cat and stop, close. When I ask you to release, just say cat, keep the tongue there, say cat, shh. Can they do that, for example? If they can't do it once, they are stimulable, and you could say that the prognosis is really good given this and this and that, because when we did stimulability testing, it showed that they were able to say the sounds given some strategies. So we need to try to continue to use these strategies in treatment and design a program that will enable them to develop the right sound production. Counseling, of course, you don't do marriage counseling. Counseling means basically informing the teacher, the parent, the caregiver about the problem, informing them about the effect of it on the person's life, helping them understand the testing scores, helping them understand the impact of the problem on, the performance and so on. Giving them strategies, say this is what you can do on your side, on your part. Giving them resources. All of these are counseling. This is what counseling in our field means. So we are going to look at special populations. For example, when you speak about people who have nonverbal and extremely limited language, you really should engage someone who has an alternative augmentative communication background. You want to see if they can have an assessment and see what are the potentials. And you also determine if the person is going to be able to use verbal communication. For the time being, they might benefit from a board or a computer system, but while you are developing the verbal communication, but what is the potential? Also, considerations for bilingual patients. We cannot, for example, if someone has an accent, that is not a disorder. It is just a language difference. It will have an impact on the ability to learn English. If they continue throughout life speaking with an accent, that again is not a disorder. So there are accent modification therapy, interventions to modify accent, or but that is optional. For the person seeks it, it is an optional thing. So, in terms of adults, during the interview, of course, you need to be formal. You need to use their last name, unless they tell you to use their first name. You need to speak to them directly if you can. So you ask the question, collect information from them directly. You should not be speaking about him or her while they are sitting right there. Sometimes even if they have mental retardation, say, okay, Mr. So-and-so are really good at this and that, and you need to work on this and that, without, minimizing the person, saying he or she while they are there. That is offensive. So make sure to refer to the person and speak with them, even if they do not have the full capacity to understand what you are saying. But because the other person, the caregiver or the parent, is there listening, and they are getting what you are saying, but you show more respect to the person who is presenting with the problem. Also, you go to the textbook and look at the case history form and see what areas the case history form focuses on, because that will tell you the needs of the adult, what kind of information will help you understand the performance of an adult. You need to prioritize your areas of focus based on what the patient needs. How is, like, that person has a stroke. How do I produce the biggest difference in the day-to-day life of that person? I mean, maybe the person doesn't even know how to say yes or no. So teaching them a simple communication system like this. Go like this if the answer is yes. Would you like steak for dinner tonight? Yes. Do you want steak for tonight? No. I am not sure. You can teach them a basic thing like that. That could make a tremendous difference in their lives for the time being until you teach them greater skills. So for adults, you need to prioritize based on what is the most important. And there's a whole system of prioritization for children that we'll speak about at different times. And so functional assessment is to evaluate the impact of language and speech problems on their day-to-day life, find out what is the most essential. Ask the patient, what are your goals? What do you want to get out of this treatment? What can I help you with? How we start first? And you list the areas that are most important for them. Like, I want to be able to go to a restaurant and order my own meal. I want to communicate with my nurses and my doctors. So you focus on what they need at first, and then you go from there. Focus on their quality of life. How will your services make their quality of life better? Again, you must document things very, very thoroughly. Write the date, write what they say, if it is quotation, if it is your own words. Reliability of reporting. Sometimes you ask a question and a person doesn't know much and they will give you an answer. Like I ask case history, when did the child say the first word? It is known. First birthday, they make a first step and they say the first word. Some of them do it at 11 months, some even at 10 months. But I got this parent who said 6 months. That is impossible. So what did she say then? I asked. What did she say? She was saying mama, 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 or papa, papa. Well, that is a babbling sound, a syllable. So it doesn't really count. So you need to be careful. Again, don't be alone with the patient, listening more than talking and stuff, because your job is to listen more, asking for clarification, for elaboration when needed. For assessment instruments, let's see. Again, there are, for the assessment instruments, we are going to speak about this in the next class. So I am going to conclude here, and then the next class will speak about assessment. The whole thing will be dedicated to assessment. So I hope that you listen to this more than once. Because even though it is not, there's no quiz on it, it will be part of the exam. Thank you.